Hi, my name is Dr. Colette Brown Graham, and I'm a general obstetrician gynecologist, primarily in the Wellington area. I've been here for over 25 years. And today, Dr. Deborah Jones and I are speaking on maternal mortality.
Hi, how are you? My name is Dr. Deborah Jones. I'm a maternal fetal medicine specialist in West Palm Beach, and I am pleased to be on this webinar with Dr. Colette Brown Graham.
So, we're here to talk about a very serious topic. And for a second, we just have to slow down and think about the fact that each maternal mortality is a tragedy. And we need to understand that this is something that the better health you have, the better healthcare systems that you have, can actually impact that significantly. Next slide, please. Next slide, please. So first, we're going to go through what maternal mortality is. We're going to define maternal mortality. We're going to talk about the racial differences in maternal mortality, go through the social determinants of health, and actually finally end up with what can be done.
So, the World Health Organization describes maternal mortality as any maternal death of a woman within 42 days of the end of her pregnancy, irrespective of the duration and the site of the pregnancy, and from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. Next slide.
The
The
measurement.
measure,
Go ahead. Go ahead.
no? Okay.
Measurement of maternal mortality is actually quite difficult because there's a lot of varied definitions, measurements, and the definitions. And so for that reason, we're going to try to define them so that it'll be better for us having our discussion going forward.
So there's pregnancy-related deaths, and a pregnancy-related death is defined as the death of a woman during pregnancy or within 1 year of the end of pregnancy from a pregnancy complication. Then there is pregnancy-related mortality ratio, or PRMR, which is the number of pregnancy-related deaths per 100,000 live births. Also, like to define what a maternal mortality ratio is, or a MMR, which is the number of maternal deaths per 100,000 live births. Finally, there's the maternal mortality rate, which is the ratio of maternal deaths to women years of exposure for women aged 15 to 49. So as you can see, Dr. Colette Brown Graham was not joking. It is complicated.
And the thing that actually is important to realize from that is that people define things differently. So we have to actually keep it keep it simple in trying to explain it to you. So first we're going to go through global mortality rate, maternal mortality. In 2017, 810 women per day died from preventable causes related to pregnancy and childbirth. And as you can see from the next slide, you're going to be able to see the slides hopefully. Between 2000 and 2017, the maternal mortality ratio dropped by 38%. The maternal mortality rate in low-income countries, though, is 462 per 100,000 versus 11 per 100,000 in high income. And I'm sure you realize that the United States is one of the high income areas. Unfortunately, when you look at it, the U.S. maternal mortality rate is actually one of the higher numbers compared to the other countries. On this slide, and I hope you're actually able to look at the slides with us, the U.S. is 17.4 per 100,000 live births. And this is the highest number when compared to countries that we like to compare ourselves to. We like to compare ourselves to France, Canada, UK, Australia. So we have a substantially higher number. In fact, we're actually 2 times as high as France and 8 times as high as Norway. So we have a lot of work to do to be in the upper tier because right now we're number 11 in comparison to all the other countries.
And Colette, I hope by the end of the lecture, we're going to be able to give them some reasons why United States is so high compared to their other countries where the income is, that are considered not third world countries.
So we're going to go through first the global causes of maternal mortality.
So
go ahead.
Go ahead. No, go ahead.
Some of them are, and these are the larger ones: severe bleeding, infection, cardiovascular disease, complications from delivery, and unsafe abortions. We talked about it. How are we doing in the USA? So we're going to ask a question. Go ahead, Dr. Jones. Let's go ahead and talk about that.
Yeah. So what we've already answered this question, but we want to engage you and ask you, since the United States have been keeping data on maternal mortality, has the maternal mortality in the United States decreased, increased, or stayed the same? Colette?
Yes, it actually has decreased, but the truth of the matter is it has increased when it comes to that of African Americans. And so with the numbers of African Americans increasing, it has actually brought the entire number up for everyone. That's really the true picture of it.
And what we found out is early on, things like delivering in, outside of hospitals, infections, those were some of the causes for the high maternal mortality in women in general. But since the 1960s, 70s, and 80s, where we have, safer childbirth, less infection, the trends have come down. But since 1987,
Correct,
we're noticing a troublesome trend of an increasing number of pregnancy-related deaths in the United States. And as Dr. Colette Brown Graham said, this is simply because the Black women, we're dying at a higher rate. And we're going to continue to discuss a little bit of why that's the case.
So 700 women die each year in the United States as a result of pregnancy or delivery complications. And that is a huge number. So we have to actually make sure that we remember each and every one of them, because 700 is a huge number for us to have lost. This is the CDC data. And you can see the trends in pregnancy-related mortality in the United States from 1987 to 2016. And that number is really being brought up substantially because of the number of African-American women that have died in this country related to childbirth. So our maternal mortality, Dr. Jones can go ahead and talk about that.
So in 2018, CDC put together, the number of deaths per 100 live births, and it's, as Dr. Colette Brown Graham had said earlier, 17.4 per 100,000 live births. And this is just another depiction, if you can see the next slide, of just how out of step we are with the rest of the industrialized countries in the world. And we have to do something about it. Dr. Colette Brown Graham is going to talk a little bit about what's happening right here at home, state by state. Colette?
Okay, so when you're looking at state by state, you can see that Florida is a lighter blue than Louisiana or Georgia. And sadly, Louisiana in particular and Georgia have a much higher incidence of maternal mortality. South Dakota is in light green. That's one of the states that has the lowest number. So we're doing okay in Florida. In fact, West Palm Beach's numbers are better than the entire rest of Florida, so we should be happy about that. But certainly we're not out of the woods, particularly when you look at, because we don't just use a Florida rate, we're part of the United States of America. And for us to improve, we have to improve the numbers in Indiana, New Jersey, Louisiana, Georgia, because all of those are a much darker blue. This just goes over what we said. The highest maternal mortality is in Louisiana, followed by Georgia. Florida is in the mix. So these are the facts. In 2018, the maternal mortality rate was 17.4 per 100,000 live births. When compared to similar wealthy countries, America is number 10 out of those 10 countries, including Norway, France, Italy, countries that we like to compare ourselves to, that are quote unquote first world countries. When compared to all countries that keep the data, the US is actually 55th, which is incredible. And part of the problem with this is that there's a wide racial and ethnic disparity. And sadly, the older the woman is, the higher the maternal mortality is. So these are some of the take-home points that we wanted to make. Next slide, please.
So more audience participation.
Racial differences.
The racial differences in maternal mortality. So maternal mortality rate of an African American woman is 2 times that of Caucasian American, no different, 3 times or 5 times. Colette?
Over 3 times. It's actually, the number is 3.4 to 3.7, depending on who you read or how they count their numbers. And that's abysmal. And sadly, as a working obstetrician gynecologist, even in West Palm Beach, I'll have patients come in and I'll say, why are you upset? And they'll say, I just read that my rate of dying compared to my neighbor, who's Caucasian's rate, is 3.4 times higher. And that's really very disturbing information to hear. So this slide shows the pregnancy-related mortality by race ethnicity from the CDC from 2014 to 2017. And as you can see, that number for non-Hispanic Blacks is actually 41.7 compared to Hispanic or Latinos, and their number is actually very good, 11.6. In fact, it's low. It's actually the lowest. Non-Hispanic whites is actually 13.4. So that just 41.7 to 13.4. You can see that number, it shows the 3 plus times higher rate of maternal mortality. We have to do better. We have to do better. Yes. The inequalities in maternal mortality really show up, and it actually is a huge sore on the American healthcare system. And I think we need to actually try to figure out how we can do better, because these inequalities do not make sense.
So Colette, I think, recognizing that there is these equalities is probably a step, a little late, but it's a step. If we could be aware of the fact that 11% isn't good. No, that's still high, but we got to recognize that Black women and Native women are dying. And once we realize that, then we can dig in and find out why, and maybe address some of the root causes. And hopefully, I know you're working hard to decrease it. I think we've been working hard for 20-something years, Colette, right? Since we've been here.
Right. Well, I think
I don't want to tell everybody, but
no. I think the first thing that you said actually makes sense. In this little seminar that we're having, is that absolute recognition. Because sometimes I've heard people say, well, my friends who are physicians who happen to be Caucasian, I don't know why this number is because I don't treat patients differently, but just even recognizing that information is actually critical. And as
Yeah.
the CDC disparities show by age, that there is also an age discrepancy. The older you are is at childbirth is also more commonly that you will actually die, which is very difficult to hear, but it's actually completely true. They have the data and the numbers to support that.
And I don't know about your practice, Colette, but a 40-year-old is not an old person having a baby these days. These are our children and our children's friends having babies in their 30s and 40s, and they're dying at an alarming rate.
And that disparity in age comes out even with the older you get. A Caucasian and a Black person, if they're in their 40s, it's the numbers are discrepant in terms of who will be dying. Caucasian woman at 17 per 100,000 is still a high number, but an African American woman, that number in her 40s is 46 per 100,000, which is a huge discrepancy. Next slide, please.
Next slide. So this slide just sort of depicts across the nation. It just shows the disparity. Even in states that have low, like you said, Dakota has a low pregnancy-related mortality rate. They still have a huge disparity. Black women die even in a low, so-called good state. They die 3 times more often than their counterpart. So we got to find out why.
Right.
That's why we're here.
I think one of the more disturbing things about this is that a college degree usually implies that you have some protection against health problems. Not so. The pregnancy-related mortality rate for Black women with at least a college degree was 5 times as high as a white woman with a similar education. So now that we painted the picture so bleak, we can keep going. Well, I wanted to give one example because this story really touched my heart. Shalone Ivering's story, and you can look her up because she actually is written about. She is from she worked at the CDC. This is a picture of her. She sadly is dead. She had a PhD, I think it was in epidemiology, and she actually went several times to her physician to complain about the fact that she just didn't feel well. And unfortunately, she died postpartum with pregnancy-induced hypertension. And that is her mother taking care of her child. So I think part of my reasoning for trying to give talks like this or even addressing it has to do with female stories like this. Next slide, please.
Just to say something on that, Colette, I hear a lot that, the reason why Black women die, they don't come for prenatal care, they don't have good nutrition, they don't take care of themselves, they, have multiple children. These are all the reasons that people give why we have a higher mortality and morbidity rate. But like you said, stories like this and data that we just presented, flies in the face of that kind of explanation, because even if we're educated, even if we do all the right things, somehow we still have a higher risk of dying when trying to have a baby. And that's the thing that frustrates me when I hear people give that as a simple explanation as to why our mortality rate is higher.
Well, go into the next slide and you can talk about that, Deborah, please, about et cetera.
So the next slide, before we get into another reason why, another good story that you have to share with us, this is just what are the leading causes of death based on our ethnicity? And the big one is, you think you have bleeding and you think you have, infection, but the big one is cardiomyopathy, which is a problem that occurs with your heart. You kind of go into heart failure. Your heart just stops, fails after you have your baby or during the latter part of the third trimester. And also, we are more at risk for having preeclampsia and eclampsia, something that we could prevent by simply, low dose aspirin. A doctor thinking, oh, this is a Black female. She might not have had, might be her first baby. She's 40. Let me give her a low dose aspirin because I know that she's more at risk for developing preeclampsia. So this, I think, is a great slide that kind of tells us, what non-Hispanic Blacks die of versus our sisters who are non-Hispanic whites.
So Serena Williams' birth story, I think she also gives a complete picture of who would be more well-known than her. And what happened with her was an absolute shame because she's one of the best, actually, if not the best known tennis player in the world. And she almost died because A, the entire medical team did not believe she had a blood clot in her lungs. B, there is systemic racism. C, she had a medical condition that makes her more prone to blood clots. Or D, all of the above. Dr. Jones?
All of the above.
Correct. So the truth of the matter is that I think one of the tenets that the CSC is trying to also bring home is that we need to have people who will hear our stories. So please, when you go to the physician, make sure that the reality of what you're saying is appreciated by the physician, because she basically had to go there and tell them, I have a blood clot. I have a disorder that makes me more prone to having a pulmonary emboli. Please treat me with heparin. I mean, that's kind of a shame that this is where she was coming from. But if she had a provider that listened to her, maybe it would have been a little different. I'm not downing her provider, but I really want us all to understand that it's important that the provider that you go to is able to hear you and listen to you. They don't have to look like you. They just have to listen and be aware of problems that could affect you.
Absolutely. Communication is essential. And sometimes people, they just don't listen to you as much or as well as they would listen to a patient of another race. And I think it's not everyone. I don't want to, say that this is a help me, Colette. What am I?
No, you're not basing it on what we're basing it on is fact, and that's actually part of the problem. Is that we're not trying to negate any one person taking care of someone. We're trying to make sure that this is something that everyone's aware of. So as a patient, patients need to speak up. Speak up if you have a question or concern. Pay attention to the care that you get. Educate yourself about your illness. Ask a trusted family member or friend to be your advocate. Know what medicines you take and why you take them. Use a hospital, clinic, or surgery center that has been carefully checked out. Participate in all decisions about your treatment.
Speak up. Okay. Most important thing we probably said for the minutes that we've been speaking. So, there are a lot of people that study, why is this happening? What are the reasons behind all of this? And, many of you who are in the audience are well versed in the social determinants of health. The social determinants of health are it's complicated. It's there's a lot of things that go into it, but the World Health Organization defines it as circumstances are shaped by the distribution of money, power, and resources at a global, national, and local level. So everything is shaped by that. Where you live, your zip code, how much money you have, how much power you have. These all
How much education you have,
impact. I didn't hear you, Claude.
how much education you have,
How
all
much
of these things.
education you have. All these things impact where you intersect with your healthcare provider.
Well,
And these social determinants of health are the major causes of a lot of health issues, such as if you live in a certain zip code, you might not have proper education, you might not have the grocery stores, you might have, therefore, you might be more at risk for obesity and heart disease, and that translates into increased risk for morbidity and mortality. Colette, I cut you off. Sorry about that. What were you?
I actually was gonna reiterate your point because it is fascinating that what your zip code is can actually imply what your health is going to be, how much education you're going to get. So it really is important in terms of your health because, and it shouldn't be this way, but your zip code really defines how healthy you will be. And I hope to be one day in a situation where this is not the that's not the overwhelming or the overarching medical environment that we live in. That anyone can come into the hospital regardless of their zip code and have the care provided to them that will allow them to have less maternal mortality and a healthy baby.
Yeah.
So
And the thing is, with these social determinants of health, it starts from, it's where you grow up, it's where you're nurtured. And if you're in a area that, you know, your zip code isn't getting the amount of money that you're supposed to get for early childhood, for childcare, for groceries. You don't have transportation to come to the doctor. There's so many complex things that impact you and will impact, like you said, where you go to school. And we're not talking about the rare person that manages to, navigate through all of these things and still rise to the top and can get out of their zip code and do well for themselves in life. But I'm talking about the general population of people that are stuck in the confines of their environment.
next slide.
Go ahead, Colette.
So the next slide, as you can see, is actually very, very complicated, but it goes through and it tries to show that governance, macroeconomic policies, social policies, labor markets, public policies, cultural and social values, how that all of this goes back and impacts your equity and health and well-being. So you can see that there's, as Dr. Jones pointed out, many things in the social determinants of health that actually will impact your health and your health care.
And it's a basis for the theory that systemic racism plays a big, huge impact on your health and your maternal outcome. You know, down to the the politicians, the policies that they choose to push through, where they choose to put the money, in what they think is important. This is one side of it. The schools you go to is another. You know, the hospital
and the thing is,
in
Dr.
your
Jones,
area.
I want to kind of say this because these are really uncomfortable issues that we're talking about. And it's uncomfortable because really and truly, we are two blessed people who have become physicians and who stand here saying that this is something that needs to be addressed. And the truth is, it does need to be addressed. There is an unequal distribution of material and monetary resources. And um, it's hard to beat that drum and not sound like I'm not unhappy with my situation. I just would like for it to be better for women who look like me. So this is part of the issue.
Absolutely.
That's part of the issue. So I do know that it's an uncomfortable situation to address, but some of it needs to be actually looked right in the face to try to figure out what we can do to make a difference with these social determinants of health, because they do impact your health substantially. Next slide, please. Okay, so audience participation. COVID-19 has shown us that racial disparity in healthcare in the United States is real, or that racial disparity in healthcare in the United States does not exist. Dr. Jones?
Racial disparity in healthcare in the United States is real.
So
It's real.
what did we do for the COVID-19 response? We're not totally in the backside of this yet because sadly this Delta variant is coming up. But we did food banks. We did $1.9 trillion assistance program. It's actually probably double that now with the Child Act that we did. We had a moratorium on foreclosures and evictions. We were finding shelter for the homeless, and we also put vaccines together. So that was our COVID-19 response. Next slide, please. And that's someone getting their vaccine. Public service announcement, our vaccines have stalled. Everyone needs one. But that was one of the cornerstones of how we cared for people with the COVID. We actually got the vaccine out. And that's why now in the United States, our number has actually stalled. Yes, we're seeing the Delta variant come about, but we really had a wonderful response to how we treated COVID-19, I thought.
I agree. They pulled the communities together and really tried to get into the communities that needed the vaccine, educate the communities that were more susceptible to COVID. I thought I agree with it was a great effort.
So I would love for us to have the same impact on maternal mortality, because that's one of the things that we thought about. How can we make this a priority and address it so that we won't be having discussions from now until 50 years from now talking about why is there such a huge difference? So the same kind of impact that we had with COVID-19, we would like to see how we could address that with the infant mortality and maternal mortality. So one of the groups that I actually try to work with is the Fetal Infant Mortality Review. What is that? It's an action-oriented community process that addresses the circumstances that affect the health of a population. It brings together key members of the community and reviews cases from individual cases of fetal and infant death, and it engages the community to take action. So there's all these different groups. One of them is the Fetal Infant Mortality. And this is information from the Palm Beach County, state of Florida, the infant mortality rate. And as you can see, this is what I was saying to you before, that Palm Beach County actually has done much better than the USA and even the state of Florida. You can see from this information that we actually have a lower rate of infant mortality compared to the state of Florida and actually compared to the United States as well. We would love for that number to be 0, but the infant mortality rate, you can see, is lower in Palm Beach County, even than the state of Florida and in the entire United States. And we did this over 3 years, from 2017 to 2020. Palm Beach County, state of Florida, you can see that. Why is that number elevated even at all? The Black infant mortality rate is actually double that of the Caucasian infant mortality. And that's actually kind of a shame, but we put them close to each other so that you could see that rate. And you can't argue with facts. This is just the fact that we looked at this and teased out the information and put it in a chart. I don't want to keep talking by myself.
Yes, just more of the, our children die at a higher rate, and we die at a higher rate, I think basically is the take-home message for that last graph there in United States. And as Dr. Colette Brown Graham was saying, there's also these are groups trying to get a handle of what's going on and see what we can do, what changes that we can make in policy to decrease the rate. And then, so there's one for for pregnant women, as there was one for infants. So there's a Florida pregnancy associated mortality review. And again, this is doing ongoing surveillance that involves data collection, examination of maternal deaths. And the idea is to promote an evidence-based action, because when you have the evidence in front of you that this is happening, it's a more compelling argument when you want to affect change and improve systems. So we brought this up at the beginning. Again, this is the Florida. Thank goodness we're, as Dr. Colette Brown Graham says, we're doing better than United States. We didn't have the 2020 or the 2019 data for the U.S., but you could see that the U.S. we were saying was about 17.4. And thankfully, in Florida, we're low. The overall, but you can see that the Black maternal mortality rate is a little high. News was in 2019; it went back up. We weren't sure about the data in 2020 if that was all collected when we looked at it, but we were a little perturbed about the trend that it was going up in 2019. Again, more depiction of the maternal mortality rate in Palm Beach County versus the state of Florida. We're in Palm Beach County. We're going to do better, but we should, congratulate ourselves for the fact that we're lower than
State of Florida.
Than the state of Florida. But if you look again, the Black mortality rate is the high one. That's the one that sort of, jumps up, especially in the 2019 data. We really couldn't find an explanation, right, Colette, why this 2019 data, just it went right up to all-time high. Go ahead, Colette.
So the next slide was part of the Florida Pregnancy Associated Mortality Review that they had the key findings for 2018. 34.3 were non-Hispanic white women, 48.6 were non-Hispanic Black women, 14.3 were Hispanic women, and 2.9 were non-Hispanic other race women. So still, again, just information that we said before, almost 50% of the mortality was non-Hispanic Black women. And going through, why did those people die? Cardiomyopathy was 20%. Hemorrhage was 16.7%. Thromboembolic embolism and infection was 11%. And cardiovascular disease and hypertensive disorders was around 8.3%.
Yeah. This is the data that, as a perinatologist, this is the one that kind of stuck out to me. Why are we at more risk for cardiomyopathy? It's not usually what we think of. We usually think of hemorrhage and hypertension. So I know they're doing some work to kind of dig in and see why this number is jumping out.
Well, I think the next slide actually, and you pointed this out to me, Deborah, when we were doing this talk before, that 81% of the people, the deaths occurred during the postpartum period.
Yes.
And that was incredible if you think about it, because ACOG, American College of OBGYNs, is trying to give us, if you will, a fourth portion of a pregnancy.
Absolutely.
So during the postpartum period, should we really be waiting for 6 weeks to see the patient? Maybe we should have them come back, everyone, 1 to 2 weeks afterwards.
1 to 2
check
weeks.
Their blood pressure and assure that they're actually healthy with regards
Right.
to all, postpartum depression or whatever, but ask them a few questions. Waiting till 6 weeks might actually miss out on 81% of the deaths.
Yes.
So I
Missed
thought that was,
opportunity. Missed
yeah.
opportunity if we continue to do the 6 week as we've always done.
What has been our response to the public health crisis of maternal mortality? Well, look at this next slide. There are so many different. There's the Children's Services Council. We're talking to the Healthy Mothers, Healthy Babies, March of Dimes, Florida Infant Mortality Review, Healthcare District, local health department, RIPIC, like you're totally involved in, the Florida Perinatal Quality Collaborative, the Pregnancy Associated Mortality Review. I'm actually happy that there's this list, but what can be done? We actually need to make all of these organizations kind of talk to each other, because everyone's in a silo doing their little bit, and we need to have them talk to each other so that each of them can actually connect the dots, so we can actually move everyone up and get healthcare better for everyone. So we're trying to have them raise awareness, understand the role the practitioner bias plays in health outcomes and healthcare, and really educate patients in a culturally sensitive manner about steps they can take to prevent disease conditions that are prevalent in their racial and ethnic groups.
Absolutely. Absolutely. And for me, raising awareness, I think, as you said, some of the partners here that we have, they're really doing a fabulous job to, raise awareness of this problem in our community and have been for years. I think practitioners, we have to probably do more to realize that we have implicit bias when we see our patients. Everybody has a bias when they enter any kind of interaction with another human being, and we have to be more conscious of our biases that we have when we are taking care of our patients, and being able to um, relate to our patients' different cultural backgrounds. I think is uh, very, very important,
Very
because
critical.
that's how a patient opens up. That's how a patient tells you things that they might not tell you if you somehow can pierce through their, you might not come from the same culture, but there's got to be some human connection that we as practitioners and nurses and hospitals make with our patients, so that we can have a good working relationship where we're listening to each other.
So, well, we actually put a slide together. What else can be done? We actually
Yeah, there you
focused
go.
in many different things that we thought would actually make a difference. We want to go through this kind of very briefly, because we've been talking now for over 45 minutes. But
45 minutes. They're banging at my door, Colette.
well, maintaining a healthy diet and weight, increasing physical activity. These things seem so very trite and almost not needed to speak about, but they are. I was actually speaking to a group of people, and we were talking about what the obesity rate among African American females was, and it is about 60% of
My
African American
goodness.
females. And so maintaining a healthy diet and weight, talking to our patients about the fact that, oh my goodness, um, you have a BMI that's elevated, you do not need to gain that 35 pounds. Maybe you could
Exactly.
gain 15 pounds instead. Quitting all
That
substance,
fast food's your enemy.
fast
Cook
food's
at
your enemy.
home.
Absolutely. Quitting all substance use, having some stress reduction, maybe increasing their health literacy. I mean, some people really don't realize the impact that having fresh fruits and vegetables have in their lives.
Yes.
Doing some preconceptual counseling, some mental health counseling. It is critical that you're in a good space when you're pregnant, or even not, but certainly when you're pregnant. Training providers in cultural competency,
Yes.
as Dr. Jones just said, implicit bias training. I think that the interesting thing about this for me is that we don't sometimes look at ourselves, because I can have implicit bias and not even realize it. And I can even be implicitly biased against someone who looks like me. So if I can tell
Absolutely.
you that in all honesty, we have to look within ourselves and try to rid ourselves of that implicit bias, because it may not
Absolutely.
even be how you treat a patient. It might be how your staff treats a patient. So monitoring people in the postpartum period and making sure everybody has a pregnancy medical home. I don't know if you wanted to add anything to any of that
No, I think,
information.
you've covered everything. Here's a little thing about social determinants. You said fruit and vegetables are important. Fruit and vegetables are expensive. And all of these things, like you said, impact your health. So somehow, if we can get healthy fruit and vegetables to our patients, I don't know. These days, WIC, do they give them fruit and vegetables? Back in the day, they never gave you fruit and vegetables. They gave you cheese and
Cheese.
powdered milk. Hopefully, they've changed that. Do they give them fruit and vegetables? I don't know.
Well, afterwards in the question and answer, we can actually answer that. But
Okay,
and we can get an answer from a WIC person.
from
Um,
a WIC person.
from somebody who is
No,
involved.
no, who works and who knows. But that
Yes.
was always my I was always so very upset. It's the cheese and the so maybe times have changed. I'm dating myself. Anyways, how do we make an impact? It's not easy, it's complex.
And a
So
minority
a
of
minority
physicians.
of physicians, practices and hospitals screen patients for social determinants. Now more and more it's becoming part of the medical record, where they do some screening to make sure that you're in a safe place, that you've got food, you've got transportation. I'm seeing that more and more, but we still, as practitioners, have to try to make the time to do that. And I know it's tough.
So I think one of the things that's also important, because this is not my data, this is what we have seen over and over, that we need to train more doctors of color, because studies show that patients of color get better care when their provider is also of color. Now, I'm not going to argue with anyone, because people will kind of almost be upset with that statement, because certainly it's going to say, well, I take care of every patient the same. But this is not my data. This is actually data that's been proven over and over again. So I think one of the things that we should do, because, and this is kind of a shame, when I graduated from medical school in 1989, yes, I am that old, um, there was a higher percentage of African American females than there is now. And there certainly was a higher percentage of African American males than there is now. So, what has happened? Why has that number dropped? I mean, we are about, wherever you want to look at, maybe not in South Dakota, but we're about 13% of the population. Why are we not? I'm not talking about trying to give people an opportunity to go to school if they don't have the grades, but I think it's important that we ask ourselves, why are there not more physicians of color? And I'm not
Yes.
talking about just Asian Americans, I'm talking about African American Black individuals. Why are there not more men and women of color that are in medical school? I think that's part of a larger problem, and it maybe would correct some of the implicit bias that we have that's going on. So,
Absolutely.
uh,
Colette, this is something, Kamala Harris and, the attempt to try and address the racial biases in our healthcare. But I wanted to go on to your postpartum
yeah,
detection slides that you found. And it was a really great study. So if you could
yes.
tell us a
So,
little bit about it.
right. Well, I actually was looking through the information when we first started talking about this, and I was very enthralled with the study that came out showing a huge detection and improvement and the management of postpartum hypertension. So, why was this important? Because of just that information that we came up with. 81% of the deaths of the African American females are in the postpartum period. Well, guess what? This study showed that if we gave everybody a blood pressure cuff, engaged them in their own care, and just had them take their blood pressure, we actually had some amazing results. Now, this is not my study. This is a study out of Twistle. And I really enjoyed reading this study because it showed that there was a 50% reduction in the amount of African American females that were actually readmitted for postpartum issues related to hypertension. And the other thing that's really critical about this study is that 91% of the patient were engaged with their care. So this is something that was a win-win for everyone because you had better health care for everyone by handing people a blood pressure cuff. And I thought that was
Something
really a
simple.
wonderful thing. Something simple. We didn't reinvent a wheel. We actually did something simple. And what happened was they actually sent the patients home with the blood pressure cuff, and they came up, and they actually, those who were they were worried about, especially, and they came up with this 50%, 49% reduction in readmission. So it went from 61 to 31. So that's if you think about that, that's really a very low cost, amazing thing. And what I want to say is I want to do a plug because we're both members of the T. Leroy Jefferson Medical Society. And the T. Leroy Jefferson Medical Society is an amazing organization of primarily African American doctors. And along with, I'm going to do also a plug for the Voter League of Women Voters because they have helped us with this study.
Right.
And we are doing, thanks to you, Dr. Jones and Dr. Stossel in Belglade, we're doing a pilot study where we're giving blood pressure cuffs. Healthy Mothers, Healthy Babies is also helping us with this. We're doing blood pressure cuffs to women with, it's a little different because the people are already diagnosed with hypertension, but we're doing a study where we're giving them a blood pressure cuff because many times their insurance doesn't give them a blood pressure cuff. And we're trying to see if that will make a difference with their overall health. So this is my plug for T. Leroy Jefferson, yes, but I'm really thrilled that we're actually, it's not the same study, but we're trying to make a difference by handing out a blood pressure cuff and seeing if it will help the overall health of the African American females.
Thank you.
Gaps in the system. Onwards.
Gaps in the system. Well, there's a lot of gaps in the system. And all of those gaps, lead to health equity issues. Payers getting access to good health care, would mean that you would need good insurance to get into, have early access to care. Providers being able to communicate with their patients on a culturally diverse way. And the patients themselves, like Dr. Colette Brown Graham just said, the patients, engaging the patients in their own healthcare, educating the patient about the things that they should be doing to try to either prevent, recognize disease, and contact their physician in a timely fashion, and supporting them getting from their appointments when sometimes they don't have adequate transportation. And speaking up was one of the other things that we want to make sure our patients do, speak up when something is bothering them. And, patients, they're sometimes, it depends on the physician, they might be afraid to tell the physician something. So they listen like good, obedient people, and they get up and they walk out. And they're sort of afraid to say, hey, I don't understand this, or this doesn't make sense. This is not what I'm telling you. This is not what I'm feeling. You don't know, what's happening at my house or my job, or the fact that I have a job, a house, I've got, 3 kids, and I'm worried about my rent. They don't want to talk to you about these things, and all those things impact their health. And then, we have programs like all the programs that Dr. Colette Brown Graham listed that are really trying to help, make an impact on health inequities. And, And as Dr. Colette Brown Graham said, that we all need to communicate with one another. We're all on team mom, and we got to do what we can to make sure that we have a healthy mom and a healthy baby. And that's why, we're all here. That's why we get up, put our shoes on, and go to work every day. Colette told me that she can't retire because she has so many people coming to her to help her. I mean, for her to help. And so that's why she gets up every morning. She puts her shoes on. She comes in to try and do the best for her moms and their babies, instead of traveling to all the wonderful places I know you like to travel, like me. So we're all trying to do our part, is basically what I'm saying, and we have to keep going.
Next slide, please.
Colette?
Yeah. So the biggest thing about health equity is that we want to make sure that the payers, programs, providers, and patients are able to all participate, and we're all listening to each other, because if we stay in our own silo, we won't get that information. So the answer to the social determinants of health, data sharing, is really critical, because if I develop a program over in RIPIC or over in FEMUR, and I don't get that information out to the entire patient population, how is that going to help anyone make anyone's health better? So we really need to make sure that the data sharing, and that organizations and providers are able to listen to each other across the spectrum, so that it'll be better. So analyzing the health data is not enough. For us to actually, we have to go beyond that, and we have to actually listen to the information and try to make sense of it, so that we can take some of that information and put it into our daily care of patients. So to make a difference, we have to actually almost actively support a change that we think will impact health for everyone. Next slide, health inequity, Dr. Jones.
Yeah, so some of the things that Colette and I sort of sat down and brainstormed when we had put this together, about what are some of the things that we can do to address it on a system-wide level. Unconscious bias training was like a big one, just that we keep going back and forth with that one. And looking within each of our own organizations to see if we have disparity in care. Like, I might think that my practice is, perfect, and there's no disparity in the care, but we need to take a hard, honest look at ourselves within our practices, within our hospitals, and analyze it and really conduct a separate analysis. We know what happens in the community, but everybody's saying it's not at my place. It's not at my place. Right. I treat everybody the same, but we need to look within and see. You said something earlier, Colette, the front office person, the nurse that brings, the person back, not just the physicians, the MAs, everybody, at hospitals, how they're greeted by the security in the front,
Correct.
how patients are made to feel by security guards in the hospital. All of these things, we really have to look and see if there's disparity in our own organizations. And the other thing is to make sure that the leadership of these hospital systems and offices, that they have some ethnic and racial diversity, and it's not, it has to have women, it has to have African American, Black people in leadership, and who can speak, honestly and candidly with the other leadership, because they might have blinders on and not realize, because of their own biases, that certain things and certain policies would affect patients negatively.
Well, I'll tell you, it was interesting. I was looking at the pamphlet for one of the hospitals, and no slides in there had anyone of color. And I thought, how is this reflective of the community that you serve? So I
Mhm.
think the racial and ethnic diversity in leadership really is important, because your hospital needs to reflect who you're taking care of. Your board
Absolutely.
needs to reflect who you're taking care of. And
Absolutely.
I don't think that's too much to ask, and I don't think that's just, as people say, propping people up or trying to put someone in just because they look a certain way. That's
Certainly.
actually trying to make sure that everyone is reflected and people are taken care of by everyone. So just like you said, there should be people of color on the board. There should be people of color as leaders. And this is important for us to reflect that for our patients' care as well. So, yeah, and the social determinants of health create links and relationships with available community resources. That's really important as well. So, right now, we wanted to know if there were any questions. And we just want to thank you all very much for sitting through our talk. And if you have any questions, we'd like to go on with that. We have a series of questions actually, that we're going to go through. But thank you very much for your paying attention. And we're going to go on with the program now.
Thank you. Thank you. Thank you.